Hi everyone, it's Rona again, PGY2 at Walter Reed for a shelf review video. This one is going to be a little bit different. I'm really going to aim for things that we don't see on the wards as often, or differentials that sound or look similar that test questions might make you pick between. And as usual, I encourage you to pause the video and test yourself as we go. So starting off, which GI condition is going to be associated with asthma? The answer for this is eosinophilic esophagitis, or EOE. And how do you diagnose EOE? So the answer is going to be a combination of symptoms, which might be things like dysphagia or heartburn, and histology. You also need to rule out other causes of medication-induced eosinophilia, but on your test, you'll most likely get something like a young patient who has dysphagia and a history of asthma or atopic skin conditions, and you'll get that histology, which is showing that 15 plus eosinophils per high power field result. And how do you treat EOE? So the first line is actually dietary modification, but if you're asked for pharmacologic options, the answers are going to be PPIs or swallowed steroids. And how do you diagnose asthma? So the answer for this is going to be spirometry to assess for reversible airflow obstruction. The reversible is the key word here. If it's not reversible, think about COPD. And then what if it's normal, but you still have a strong suspicion for asthma? The answer for this is the methacholine challenge test, which is assessing for bronchial hyperreactivity. And just remember that a normal PFT at baseline is not going to rule out asthma. And what if you have a patient who has difficult to control asthma? You notice that they have an increased IgE on their labs, they have positive skin test to aspergillus. So that aspergillus is really going to be our buzzword here. They're trying to get you to think about allergic bronchopulmonary aspergillosis. So just thinking about some things that can mimic asthma, we already mentioned that ABPA could be something that mimics asthma if you have difficult to control asthma with that aspergillus skin test. What if someone has difficult to control asthma, they also have chronic sinusitis, and then you notice that they have this elevated P-ANCA? This one is going to be our eosinophilic granulomatosis with polyangiitis, or EGPA. You may have also learned it through the name Churg-Strauss. And EGPA and all the other vasculitis conditions always confused me when I was studying for them, so I just wanted to go into these in a little more detail. So starting off with EGPA, can you think of any other organs which could be involved? So as you can see, a lot of different organs can be involved, which is one of the reasons why this is so confusing. This is going to be one of your ANCA vasculitis conditions, so it's going to be a vasculitis, but cardiac conditions are actually the #1 cause of death. Many of these patients will develop heart failure. They can also have conduction system disease with things like bradycardia. They can also have abdominal pain from things like GI involvement, palpable purpura, you might see some dermatologic signs, glomerulonephritis if the kidneys are involved. They can have some sensory abnormalities with nerve involvement, and a big buzzword you're going to notice is eosinophilic tissue infiltrates. So this is our P-ANCA. You might also see anti-MPO. And there's another vasculitis which is also associated with P-ANCA and also associated with renal involvement, lung involvement, could potentially have hearing loss as well. Can you think about which one this might be? So this is going to be our microscopic polyangiitis, or MPA, and this is one of the reasons these questions are so confusing, is you can have these conditions that both have P-ANCA, both have similar organs which could be involved, and you're going to be asked to differentiate between which ones they are. Just as another example, what if you have someone who has C-ANCA instead of P-ANCA? You notice they have a saddle nose deformity or nasal septal perforation, and they have granulomas. So this is trying to get you to think about granulomatosis with polyangiitis, or GPA. You may have also heard about it as Wegener's. So, and just remembering also that for Wegener's, you could have severe upper airway involvement, so they may tell you about tracheal or subglottic stenosis. So just looking at these, and I really wanted to highlight some things. So microscopic polyangiitis and EGPA both are associated with P-ANCA. Note that GPA is the only one of these three which has C-ANCA. GPA is also the only one of these three that has that severe upper airway involvement with the tracheal stenosis or that nasal saddle nose deformity or the nasal septal perforation. But all of these can look similar when you're seeing them on an exam for someone who has glomerulonephritis and some ANCA. So there are a couple of buzzwords I really want to emphasize when you're trying to differentiate between these things. So vasculitis, if you see ANCA, think about is it a C-ANCA or a P-ANCA? If it's a C-ANCA, they're trying to get you to think about GPA. If it's a P-ANCA, they're trying to differentiate between EGPA or MPA. And if they have significant nasal involvement, like they have a saddle nose deformity or septal perforation, they're probably trying to get you to say GPA. If you see any evidence of granulomas, think about GPA. And then that anti-PR3 is going to go with that C ANCA, so that's going to be GPA as well. Remember that for the eGPA or the MPA, those are going to be MPO or P ANCA, not the PR3. If they have any evidence of eosinophils or they have prominent heart failure conditions, think more about eGPA. And then if they have hearing loss, that's most likely MPA, which is the only one of those three that has ANCA positivity in hearing loss. That's more prominent. And if there's upper airway involvement, they're probably not trying to get you to say MPA. And then if you see things like tracheal or subglottic stenosis, think more GPA. So keep these buzzwords in the back of your mind. Again, it's very confusing to differentiate between the ANCA vasculitis, but there are some buzzwords that they'll always involve, so you can pick between one of these three conditions. And so vasculitis, this is again in general a topic we don't see very frequently, so I wanted to differentiate some of the small vessel vasculitis. They can look pretty similar, all of them can have some renal involvement or a rash, so I wanted to differentiate how do you pick between these options. So if it's an ANCA vasculitis, they're always going to try to get you to pick between GPA, MPA, or eGPA, so just think about those three conditions. What about if someone has those Henoch-Schönlein purpura, abdominal pain, glomerulonephritis, maybe they had a recent upper respiratory infection? This is going to be our IgA vasculitis, and this is more common in children, so you're not going to see it as much in adult patients, but in pediatric patients it can be associated with intussusception, and treatment is going to be supportive care. What if you have someone who has palpable purpura, arthralgias, and low complement levels? And now this low complement levels is going to be a big buzzword for you because these ANCA vasculitis conditions, the complement level will be normal. So remember, if the ANCA is positive, think about these three conditions. If the ANCA is negative or the complement is low, think about things like cryoglobulinemia. And for cryoglobulinemia in particular, you should be testing patients for hepatitis C. You might also see some elevated liver enzymes. And if the hepatitis C is positive, you should be treating the underlying cause. So let's just go through examples and see how we could apply these to questions. So let's say you have an 18-year-old female with palpable purpura on her legs, abdominal and joint pain, low-grade fevers after a recent strep infection. So this is leaning more towards that IgA vasculitis. What about a 35-year-old with hemoptysis and positive P ANCA, normal complement levels, pauciimmune, crescentic glomerulonephritis, who has normal eosinophils, coming in with foot weakness, a leg rash, and hemoptysis? So remembering our buzzwords here, remember P ANCA, they're trying to get you to think about MPA or eGPA, and then you have the normal eosinophils, so they're trying to get you to think more about MPA. And what about a 52-year-old female with 3 years of recurrent sinus infections? She's coming in with stridor. You notice she has some erosion of her maxillary sinuses, pain when you palpate the trachea, and a positive C ANCA. And again, remembering all of our buzzwords here, you have that positive C ANCA, which tells you something already, but you also notice that she has erosive disease of her sinuses, and she's having stridor with palpation, pain on palpation of the trachea. So this is trying to get you to think about GPA. This is trying to differentiate, do you know C ANCA versus P ANCA, and do you know the clinical features? And then what if you have a patient who's coming in with palpable purpura, they have low complement levels, and a positive hepatitis C? So this one, they're trying to get you to think about the cryoglobulinemic vasculitis. Again, note, because the complement level is low, they're not trying to get you to think about those ANCA conditions, and that positive hepatitis C is also going to be a big buzzword for you. And then going back a little bit again to differential diagnosis. So we mentioned for aspergillosis, ABPA is a type of aspergillosis infection. Usually it's going to present in patients with things like asthma or cystic fibrosis, but it can present like difficult to control asthma, a positive skin test, and elevated IgE. But I did want to go over 2 other ways that they might test you about aspergillosis on your test exam. So what if you have a patient with a history of TB who's presenting with cough and hemoptysis, and then on imaging you notice an upper lobe cavitary lesion and you're worried about a fungal ball? So this is going to be your aspergilloma. And what about someone who's a recent stem cell transplant, so they're immunocompromised, and then on imaging you notice these pulmonary nodules that are surrounded by a ground glass infiltrates? And the buzzword that you might see on your exam is the halo sign. So that's going to be that target lesion surrounded by ground glass. And in this condition, that ground glass is actually reflecting hemorrhage. So this is trying to get you to think about invasive pulmonary aspergillosis. And how do you diagnose invasive pulmonary aspergillosis? So the answer for this one is going to be our serum galactomannan assay. And then this is just an example of an aspergilloma. You can see here, you see this cavitary lesion with something inside of it that's concerning for a fungal ball. And you can see again here, this cavitary lesion with something inside it concerning for an aspergilloma. And finally, this is actually just an example of what you might see for invasive aspergillosis. You're seeing that target lesion here, and then it's surrounded by these ground glass opacities here, which again are going to reflect hemorrhage. And this is going to be that halo sign buzzword you might see for invasive aspergillosis. All right, so that's all I have for today. I would again love to hear your feedback. And just to summarize, today we started with asthma and associated conditions or differentials like EOE, ABPA, and EGPA. From EGPA, we went into how to differentiate conditions when you're presented with a small vessel vasculitis. And finally, we went into how they might test you on the different presentations of aspergillosis.